I will be talking on management of the defects because of osteomyelitis. So what happens post debridement and sequestrectomy commonly is we end up with small defects, medium defects, or really large gaps. And it's our job to manage them efficiently so that there is a good healing as well as less complications of shortening, angulation, as well as pathological fractures. The management of dead space can be done by using autogenous bone grafts. But if you do it in the acute situation, there is always a chance of reinfection, and they are usually performed as a second stage procedure. And the drawback is that in very small children, you get a very limited quantity of bone graft available to you. Allogenic bone graft can also be available from the bone bank, but you are always worried about the risk of infection and flaring up of infection and rejection of the allograft. For many years, we have been using antibiotic impregnated beads, or the PMMA beads, gentamicin beads as they were called, but they are not biodegradable. They do release the initial bolus of antibiotics, but then there is a rapid decline in concentration, and then it acts like a foreign body, which may be an nidus for further infecting. So current state of art treatment for these defects is use of stimulan or semi-synthetic hemihydrate of calcium sulfate, which has to be freshly prepared on table. So these cure at low temperature. They are also conductive, biodegradable, and you can mix a variety of antibiotics into these, including gram-positive and negative. That is how the preparation is made. There is a sort of a sieve mesh which is available, a rubber mesh, on which you mix the powder and the diluent and the antibiotic of your choice. And then you create pellets of varying sizes depending on the size of your gap. So just to highlight a few cases here, the small defects in the proximal radius, as you can see, this has been curated out, debrided, and then it has been filled with the stimulant granules. And that is after restoration of the bone. And you can see how nicely the calcium sulfate granules incorporate and encourage new bone formation and restore the anatomy pretty well without having the need of another surgery to remove them and have taken care of the infection. This is another case in the lower femur where you can see that post debridement, there's quite a large medium-sized defect here, which has been filled with stimulant granules. Again, my choice of antibiotic here is vancomycin because 80% of the times the bug is usually Staph aureus, MRSA, or MSSA, and vanco is pretty effective against both. So that is how over a period of time you can see that there is resorption of the granules and integration into the bone with complete resolution of the cavity. In case of longer defects where you may anticipate that there could be a fracture, you can always add an intramedullary pin or an elastic nail to stabilize so that there is no pathological fracture and protect it with a plaster. So this is another young child who had an infection in the hip as well as shaft of the femur, and that is the intramedullary rod with calcium sulfate granules, and that is how it restored, and then we could safely remove the rod without a complication. That is a longer follow-up of how the bone has remodeled at 2 years post-op. And a really large defect here again. So here you had pockets. Really, I had 2-3 pockets with intermediate bone which was pretty decent and the fibula which was intact. So I chose to pack each pocket after debriding and taking out the sequence. I packed it with stimulant, and over a period of time, again, as you can see, the entire shaft of the tibia from the middle to the ankle joint to the fascial plate has regenerated very well without any flare-ups or any kind of further complications. Another example of a posterior tibial osteomyelitis, again a nail with stimulant, and that is how it is remodeled. So this is the beautiful restoration of anatomy that a stimulant can give you. So an antibiotic impregnated calcium sulfate is very effective. It's also conductive. It's a good space filler, and it's absorbable in 3 months to 6 months. Usually foreign body reactions don't happen, but I've had a couple of times a serious discharge when the granules were in soft tissue, but that stops with a couple of dressings. and there's no real deep-seated infection. When you are dealing with large gaps or large defects, it's a complex problem where we must be sure of infection control, and then there are so many problems to be dealt with. How do we give stability? What is the vascularity? Can we regenerate the bone? What is your surgical skill, and what is the cost to the patient? So you have these options for regenerating bone, delism or fixator, using a live vascularized prefibular graft, or what was done as Chacha's or Huntington procedure, the tibia to fibula, and the non-vascularized fibular graft, which I will talk about. So the Ilizaro fixator has got good healing rates of 85 to 96%, but it needs some instrumentation. You should be used to it. It's a bit cumbersome for the kids. There's a higher rate of major and minor complications, and compliance is always an issue with ring fixators. Free vascular fibular grafts again have a union rates of about 80 to 90%, but you need a vascular pedicle in a small pediatric leg. Finding it is difficult, then you need expertise with a plastic or a vascular surgeon, and there are chances of refracture and rethrombosis of the vessel. The microvascular graft may really fail and become a dead fibula. Tibia profibula is easy to do, but it does not align the mechanical axis and causes deformation. So this is an example where a tibia profibula was done in situ, a proximal osteotomy and translocation, and that healed pretty well with a cross union. But you see the axis of the leg got pretty deformed, and though it hypertrophied nicely, the ankle was in varus and the proximal tibia, and there was a significant shortening which needed further correction. So the aim was to achieve union with a non-vascularized fibular graft. You must be very sure that there is no more infection there, the dead bone should be out, and the hematological parameters are normal, CRP is negative, and there's no discharge for at least 6 months. A nuclear scan may help you to see if there is any residual lingering infection. So this is an example where the tibia had a large gap. So distractors can be used to realign the soft tissue envelope, restore the length, and allow for some vascularity. Then you open the medullary canal on either side with a drill, and an appropriate size prefibular graft is taken from the same or the opposite leg, depending on your choice and stability. I take it subperiosteally. Taral has his way of doing it percutaneous. So this is an example. You prepare both the ends, open the canals, then harvest the fibula, and then with a thick intramedullary rod or a K-wire which goes across the ankle and transfixes the graft snugly, you thread the strut over the graft, and then you pass it like that so that it holds the graft very snugly into the gap that is available. And then you seat it in the proximal fragment and push your K-wire or pin across. Shortening is usually accepted for better stability and bone contact, and then appropriate immobilization for at least 3 months to 5 months is required. So that is how the graft is snugly fitted with the K-wire holding it, and then you give a cast. Post-operative protocol is you will always have a protection and prevent a refracture, and then follow it up with a PVC brace and appropriate shoe raises. Patients are reviewed 6 weekly, then 3 monthly, and then X-rays are taken. So some case examples to highlight what I just spoke. This is an entire sequestered tibia. That was the gap. That is the distractor. And then we reconstructed using the same sided fibula here. I didn't want the fibula to overgrow. And that is how it healed up nicely. And you can see that the resected, subperiosteally resected fibula has come back. And I've taken out the growth plate, so there is no low risk of recurrence of varus. And this has maintained quite nicely. And later on, we had to just do lengthening. So this is an example of a tibia. This is an example of a femur where there's a large gap post osteomyelitis. Again, this child was very young, so very thin fibula, threaded with a K-wire and an external fixator with a Thomas splint was given. It partially healed but went into a hypertrophic non-union, and then we had to just stabilize it with a plate, and then it healed up nicely. And then we lengthened it with a LRS and got a decently long leg, which the child required. Radius, again, a gap, use a distractor, get the length back, and then put a fibular strut with an intramedullary rod. And that is over a period of time how it regenerated, and that's a 2-year follow-up with excellent function. To conclude, free vascularized fibular strut grafts is a good procedure. We had 92% union rates. after the index procedure. It's pretty simple technique, no instrumentation which is specialized is needed, can be done by an average surgeon, and it's inexpensive. And for those who want more details, we have published this in JBJF in 2013, and you can go through that article. Thank you very much for this opportunity.